and about 3 to 5 minutes apart. Okay, once we get to that point, now it's time to ring up the hospital. Our waters haven't broken, chances are. If they have broken, then we ring the midwife, ring the hospital. My waters are broken. Just be careful that you can see that there's an obvious difference between the bloody show, the mucus plug coming away, and the ruptured membrane. So the water's breaking, ruptured membranes might be a cup or two worth of fluid gushing from the vagina, and it will continue to trickle. And as the mum feels her baby's head moves, there'll be another trickle vaginally and another trickle vaginally. So it will keep on leaking out. Now, it's not a dry birth. We don't lose all the fluid. The placenta replaces the fluid to the tune of about 1/2 litre per hour. So there's another reason. If our waters break, we definitely need to keep up fluids. Put on a pad, give the midwife a call. If she says, yes, I want you to come on in we go. Take the pad with you. Let her have a look at the pad. Okay? Good idea to buy 4 or 5 or 6 packets of maternity pads and change them very frequently. Can't wear G-string undies with maternity pads. Maternity pads are the longest, the widest, the thickest, with wings. They're referred to as surfboards. Okay, so G-strings are not compatible with those. We need bigger undies for those. So here you can see the cervix is thinning out, opening up, and moving to full dilation. The way that the midwife knows how far along a woman is very carefully and gently, gloving up, 2 fingers inserted into the vagina to the top of the back of the vagina to have a feel of how far thinned out and how far opened up the cervix is. So they are well trained at measuring. So we can't see any of this from the outside. She has to go by feel. Now, for your mothers and your grandmothers, they had vaginal examinations at every visit in their pregnancy. Isn't that amazing? And I doubt that you've had any vaginal examinations in your pregnancy. They had vaginal examinations every hour on the hour during their labour. Okay, and so if you've heard about that, you'll probably be going, ooh, I'm not keen. So the good news is you've probably not had any vaginal examinations during your pregnancy, unless they were medically necessary. And then during your labour, there will be vaginal examinations offered upon admission into hospital. Not the minute you step through the door, but the midwife will observe, and if she can see, no, you're definitely, obviously not in labour, then she'll let you know that. To confirm one way or the other, she will glove up and do an examination. She'll ask permission first. I'll check your blood pressure, I'll check your baby's heart rate, the lay of the baby, and is it all right with you if I do a vaginal examination for you as well? That would be the way the conversation goes. Then when she does, she'll be able to give you a progress report on what position your baby's in, how far thinned out your cervix is, and how far opened up the cervix is as well. Okay? So sometimes people are extremely excited. They hit the hospital very early on and they're nothing dilated yet. Okay? Sure, they're in a little bit of pre-labour, but the excitement is what propelled them in. Or maybe their partner has been terrified and has taken all his information off Hollywood television, and what he's learnt from Hollywood television is, she's gone into labour, I panic, I get her to hospital as fast as possible. Now, it's not the end of the world. What will happen is we've packed the car, we've gotten into the hospital, we've found a parking spot in the parking area, we've gone in, the midwife's examined us, we've had to repack all our stuff, turn around and go back home, because it's pointless being in the hospital for 3 days in pre-labour. If we do stay, then we're far more at risk of further medical interventions, such as being augmented or induced, maybe an epidural, maybe a caesarean section, and that may be only because we went in way too early. Okay, so what we want to do is stay at home for as long as we reasonably comfortably can. The best measurement will be when we've rung the midwife and the midwife says, you're good, stay home, everything's fine. She'll do a phone assessment, or when our contractions are about a minute in length. So midwives tend to calculate that anything less than a minute in length is probably not said to be doing very much at all. If the midwife can tell that yes, we're in good cracking labour, yes, they're regular, yes, the pattern of those contractions is that they're getting longer and stronger and closer together, and they've hit the minute mark, she may say, how do you feel? Do you feel ready to come on in? And if you do, you're very welcome to make your way in. There's no need to panic, there's no need to rush. Take your time. It is, after all, just your first baby, and we've normally got plenty of time. Okay, so very important that when we go, that we're open to the idea of maybe I'll be in good labour and stay, but maybe not. But it's reassuring to get checked out anyway and then come home. Okay. Now, a woman who has come home to her own bedroom, her own bathroom, her own food, the smell of her own house, and so it's more comfortable, it's more relaxing, it's more private, it's more quiet compared to a great big busy hospital, and she's far more likely to relax and get into labour quite well. So the hormone that we're after, lots of, is oxytocin, the love hormone. The hormone that is the antidote, if you like, to oxytocin is adrenaline. If she's scared, if she's nervous, if she's anxious, if partner is anxious, it'll rub off on her, triggering her adrenaline, squashing the oxytocin, and she won't get into proper labour. If we have failure to progress, then that is usually going to lead on to a caesarean section. Caesarean section, of course, is major abdominal surgery, and many people would rather not begin motherhood with major abdominal surgery. So a key factor is don't rush into the hospital too early. So here's where the baby is rotating around. So you already know what's actually being done by the uterus. The uterus is going hard and tight, thinning out the cervix, opening up the cervix, but the baby is an active participant in this process too. And the baby will kick to rotate itself around. The head will be pressing against the pelvic floor muscles, and the pelvic floor muscles act like a gutter to help rotate the baby. So the baby will sort of corkscrew its way through the pelvis. So the baby's head is pressing against the cervix, and especially when we're active and upright, using active birth techniques, then we're going to shave off quite a bit of time from the labour. If we lay that woman down, it will slow the labour down. Stand her up, it'll hurry the labour up. Do you know something else? It's going to be 1,000 times more comfortable for the woman standing up rather than laying down and having a whole lot of pressure on her back. There you can see the bloody show that I mentioned to you before, the mucus discharge coming out vaginally. The cervix is now completely open, and this is the beginning of the pushing phase, the beginning of second stage. So there you can see quite a bit more of the baby's head coming down. There's mum pushing, and there's when she's resting. We get a pushing contraction. That's where the uterus has now changed its action completely. The uterus goes hard and tight, and it builds up and it builds up. And when it peaks now, there's a wonderful urge to bear down. And then it backs off a fraction, and then another urge to bear down. Then it backs off a fraction, then another urge to bear down, and then that contraction stops completely. And then we get a break where we're at rest. And that's where we want a sip of water, and eyes are closed, and just collect yourself, regroup, recalibrate, and then get ready for the next contraction. And when that comes, it will not feel like the contractions did when the cervix was opening up. This is simply a pushing feeling, a bearing down feeling. So the woman may feel it welling up in her throat and then going through the core of her body, and it becomes stronger, 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 and then a very big desire to push. And a lot of women love that phase because they feel like they're getting something done. It's wonderfully energetic. They feel their baby's head moving down. And I have been at births where women have laid on their backs, and I felt so sorry for them because the baby's head is coming out. She's putting in a lot of effort. She's pushing uphill. The angle of the vagina is uphill when we're laying down. And then when that contraction stops, it slides back in. And often you hear those women say, "Oh no, I can feel it sliding back in." So after all that effort, whereas I've been at plenty of births where she's been standing or kneeling or squatting and it's not moving back in. Any bit of progress she made, she keeps on making progress, more and more. It's a much quicker birth. Now when it's a quicker birth, it's also kinder to the baby. And it's certainly kinder to partner too, isn't it? Because it's a quicker birth and partner's not as exhausted. But when it's kinder to the baby, it means that our baby's going to be in better condition after the birth as well. Now, here you can see the vagina stretching. And here you can see crowning. So this is the widest diameter of the baby's head. This is the maximum stretch for the mum. And this is something that a lot of women are concerned about. Women are concerned about the pain of labour, but they're also concerned about, am I going to be able to manage to birth my baby's head without tearing and without being cut? So I have something to show you which will help with that. It's referred to as the Epino, and I have a brochure here for you that I'll give you in a moment. Epino stands for episiotomy no, and this is a little kit that I can demonstrate for you. Epino stands for episiotomy no. It was developed by a German obstetrician who did not like cutting, using scissors to cut women's vaginas to allow for the baby's head to come out. So what he did was design this. He's fashioned it off what African women do, and that is pre-stretch the base of the vagina. And so for many people, they'll learn about perineal massage, which you'd normally start from 34 weeks onwards, and that involves the use of our thumbs, the mother's thumbs or partner's thumbs, to pre-stretch the vagina, the perineum, or 2 fingers inserted into the perineum, plenty of oil or lubricant to pre-stretch that area. So Indigenous women all across the world for centuries have known that this is quite significant, and it needs to be pre-stretched slowly, gently, a little tiny bit every day for the last several weeks of the pregnancy. So this is very suitable to use from 37 weeks onwards. Insert the blue section into the vagina. The mother controls this for herself, and then puff that up to a comfortable, firm fullness. Hold it in place for about 10 minutes, and then very slowly, so just get it up to a comfortable, firm fullness, hold it in place. If you didn't hold it, it would probably pachung across the room, and then allow that to ever so slowly, gently, gradually come out. Only use water-based lube, okay, and then once that's come out, rest for a short while, and then if you want to deflate it, insert it again, and then hold it in place for 10 minutes, and then just a second time allow that to slowly come out, and that will help pre-stretch the vagina. Over a period of several weeks, you will finally, if you just puff this up a tiny little bit every day and insert it, hold it in place for 10 minutes, maybe do that twice, and finally you will eventually get this up to about 10 centimetres. Anywhere between 7 and 10 centimetres is perfectly fine. And then you have pre-stretched the vagina ever so gently and slowly, which is perfectly safe. And then I think that's about right. I've got a measuring gauge here. And then the chances of tearing or needing to be cut, so that's about 10 centimetres. So that's adequate. That's all we need to do. And when women get to this part of their birth, they're very, very glad that they've used the Epino. It's a much quicker birth, a much easier birth. The risk of tearing is diminished very significantly, especially if she's not actually on her back, but even if she is on her back, there's much less risk of tearing. The other thing that's significant is that it will be a slightly quicker birth. Instead of maybe taking 2 hours to birth the baby, it'll probably only be about 20 minutes, 25 minutes, somewhere around there. Now what we end up with is a mum who's not tired and a baby who is not tired. Now the other thing I'd like you to notice, and you probably already have noticed this, is here's the baby's head, so you can see the little skull bones there. There you can see mum's pelvis, and you can see that when she's laying down, her pelvis is at its most closed. So that's a lot harder on the baby's head. When she stands up or squats or kneels, it's a much more flexible pelvis, a much more open pelvis, which is kinder and gentler to the baby during the birth. So using the Epino and active birth positions can make a world of difference. The other thing that the New South Wales Department of Health is recommending is water birth, water immersion, running the bath and getting the woman in the bath after about 5 centimetres, and many women will actually dilate up much more rapidly that way. They will birth in the water, and when they do birth in the water, it's a kinder, gentler birth. Babies are in very good condition when they're born through water. Baby comes up to mum, just the same as a dry land birth, skin to skin contact, lovely cuddle, and then we step out of the water to deliver the placenta, usually within about 10 minutes or so. the mother will step out of the bath, cuddling her baby and rest on the bed and then ready for breastfeeding. So it's very, very important to know that we do have options. Perineal massage, yes, or the use of the Epino, yes, to help minimise the discomfort of second stage, the pushing phase. Certainly kinder to the baby and kinder to the mum. So here you can see, very importantly, the baby's head has moulded. Now that means that the little skull bones have changed shape, they've overlapped a little bit, and the baby's head has changed shape so that it does fit down through the pelvis better. For your grandmother's generation, they often had a pelvimetry, or a measurement of the baby's head and the mum's pelvis to see if this was a big baby. And all obstetricians were told about 20 years ago, stop it, because that's not accurate. You're measuring a full-size head that's not moulded at all, with a pelvis with a woman in a laying down position at its most closed. So that's not accurate. The woman should have a trial of labour to see if she can birth this baby herself. And so having a trial of labour means that we'll give her a go and let her try to birth her baby. If that works, yay. If the baby's head moulds beautifully and the baby's head comes out on its own, that's fine. If not, we've got that as a little insurance policy in the background that we can go and have a caesarean section if necessary. So once the baby's head is out completely, then we have a rest. And after every single contraction, I appeal to all of the partners, make sure that you have water, bendy straw for the mum, lift that up and give that to the mum. Offer her a sip of water after every single contraction. She won't drink very much, but she will need that to replenish the fluid in her mouth. She'll feel a lot more comfortable. It'll be a very comforting thing for her too, and it will help her to keep on going. So remaining well hydrated is important. Baby will rotate around once the head is out, and this does not hurt at all. You will feel the baby rotate, and it will feel just like the baby moving inside your belly now. Okay? So the baby rotating around is just lining up its shoulders, getting the shoulders ready to be born. And when the baby is born, one shoulder will come out, the other shoulder will come out. So a couple of things are happening right now for the baby. One of them is that the baby is being very significantly compressed. So that's going to trigger a lot of adrenaline in the baby form of adrenaline in its system, and that will flick the baby on, making the baby very bright and very sparky, really alert, really wide awake. And that's a very significant difference between a vaginally born baby and a caesarean section baby. So caesarean section babies are wonderful and lovely, but not quite as alert as a vaginally born baby. So Mother Nature intended babies to be born vaginally. They were squeezed and compressed. That will cause the fetal lung fluid inside the lungs to get taken up into the structure of the lungs that are not yet inflated. And then when the baby does come out, the baby's very likely to breathe extremely well and have oxygen transfer very well. So when the baby is born by caesarean section, especially if it's what obstetricians call a cold caesarean, that means that there was no labour contractions at all, then the baby might be more at risk of what we call pulmonary hypertension, the heart beating very fast. In other words, they're sort of panicking. Gosh, what just happened? I got born accidentally without realising I was getting born. I had no warning at all. Or respiratory distress, and that's because their lungs weren't prepared for breathing when they were born by a cold caesarean, or even a caesarean where they've had a few contractions beforehand. So there's a very significant difference in babies, their health, their vitality, their energy, their reactionaryism after being born by vaginal birth. They tend to be in far better condition, far more likely to breastfeed extremely well, and far more likely to breathe very well and function normally. So when a baby is born vaginally, the adrenaline is up very high, and when their adrenaline begins to dissipate, same as us, if we've had a big turbocharge of energy and a big adrenaline charge, then as that starts to dissipate, we get hungry. And we start to fossick around going, there must be something to eat. There's got to be something to eat around here. And then when we eat, what do we want to do next? Absolutely. We want to go to sleep. And that's exactly the behaviour of a newborn baby. So they come out extremely bright and alert. They breathe within 1 minute, not 1 second, but within 1 minute. And then they want to latch onto the breast, usually within a half an hour to an hour. And then after that, they want to sleep. What I recommend is that we let our baby feed for about an hour. And then when the baby has finished feeding off mum, to then go on to dad. So for dad's t-shirt to come off and for the baby to have at least 20 minutes skin-to-skin contact with the dad. Okay? All right. Now, the head is out, and this is where the mum and dad can touch their baby, or dad could receive the baby with the midwife's guidance. There's the midwife's hands there, and many more dads are receiving their babies. They want to be much more involved, certainly compared to the previous generation. And you can imagine, can't you, when a baby is born, if over the next couple of years the baby is saying, how was I born? Where did I come from? And wanting to know about the day that the baby was born. If it was dad that received the baby, he can say, oh, you're asking me about that. Come and sit up here and I'll tell you about your birth. You, when you came out, I was the first person to receive you. You were that size. You fitted into my hands. And then the baby will feel very loved and wanted and rather thrilled that it was dad that held me first, and then dad handed me to mum, and mum had a lovely cuddle with me. And what dad can do next is wrap his arms all around mum and baby, and that's the first family hug, the first family cuddle as well. So there you can see the baby emerging. This is what used to be done years ago. The baby left on its back, the cord clamped too early. You can see the curliness of that cord. It's actually too soon to clamp it. There's blood, oxygen and nutrients in that. What I recommend is asking for delayed cord clamping. You may have heard of that before. If not, that's fine. You only want to delay that by about 5 to 10 minutes or so. Anywhere in there is fine, so that the baby receives what Mother Nature intended the baby to receive. Of course, we can't do that with a caesarean section at all. It must be immediate cord clamping. But with a normal vaginal birth, it is very beneficial for a baby to have delayed cord clamping. So normally what happens is that the baby is born, the baby is straight up to mum, skin to skin. It doesn't have a top on, an exercise top or a crop top or a bra. The baby is straight up onto her breast. It will stimulate her breast, her nipples, her areola. That will send a message to the pituitary gland to release oxytocin that will act on her uterus, expelling the placenta and reducing blood loss. So the healthiest and the safest is skin to skin. The baby will nuzzle around and lick and taste. Did you know that the baby, the length of the cord allows for the baby to come to the breast, not the other side of the room or anywhere else, but from inside to outside and up to the breast, but also the distance that a baby can see is about the distance from the breast to the mum's face. So dad needs to come in nice and close, doesn't he? So from the breast to the about 8 inches, about 20 centimetres. So they can see clearly, but mostly shades of grey, okay? And they're very interested in darker colours. Their companion inside the uterus was the placenta up on the wall, and that's a very dark blood colour, maroon. And isn't it interesting that the nipples, the areola, has gone to that sort of colour during the pregnancy. So it's like the baby will go, oh, look at that. I got fed by something like that before, and maybe there's my source of food. Or that looks familiar, and it's round, the same as the placenta used to be. Isn't it interesting? So there you have the new family, mum, dad, baby, bonding together. The lights are down low. If the lights are up extremely bright, then you see babies struggle against the light, and they're desperate to have a look at their mum and dad, but they're struggling like crazy. And so the kindest thing is have the lights down low or off completely, so that the baby will be able to open up its eyes easily and look right at mum, and the baby will be really interested in the roundness of mum's face, mum's eyes. The baby will be desperate to hear mum's voice, and some babies when they come out will make a liquidy sort of sound, and then a mewing kitten sound, and then launch into a big cry, or even more. And what the baby really needs is to hear mum's voice, and that's immediately reassuring, but the baby also needs to hear dad's voice too. Most parents are stunned when their baby's born, and they're like, and as quiet as. So it's better if they get told, you know what, it's better for your baby if you do have a bit of a chat to your baby. Some parents don't even know what to say, and they're like, hello. All right, so thanks for listening today. Hope you've enjoyed the session, and it's time for us to have a break, and then we'll move on to part 2.